So, good morning, ladies and gentlemen. It's my great pleasure to present you about a recent case from our department. This case report is about a 15-year-old patient with no significant past medical history. He's an active athlete, a hockey player actually, and last year in winter he had an EBV infection. After that he was fully recovered, and then the same year in summer he had 2 viral infections. A month later,
You suffer too much.
Thank you. A month later, 2 days after hockey training, occurred dyspnea and weakness, but with no fever or cough. And he was administered in a local emergency room where the echocardiogram was performed with severe left ventricle dysfunction with ejection fraction of 15%. Then he was transferred to our department where on admission there were signs of acute heart failure, NYHA class 3 to 4, ventricular tachyarrhythmias, hypotension, and lung crickles, peripheral edema, and mild ascites. So the initial therapy for this was inotropes, furosemide, and amiodarone. In labs there was CRP17, so there was like mild elevation of inflammatory markers, mild elevation of TNT, and in serology there was positivity for IgM and IgG antibodies for borreliosis and EBV. So then, after stabilization, the therapy, we started with the therapy of heart failure and also with antibiotics for the borreliosis. So now let's take a look on the findings on admission. So first there's an ECG where we can see that there's normal sinus rhythm with heart rate 80 beats per minute. Then we did the echocardiography where we can see that there's severe dilatation of left ventricle and of right ventricle with severe dysfunction. Also there's mitral and tricuspid insufficiency, second grade of mitral insufficiency. And then we did the cardiac magnetic resonance where I would like you to notice this ring-like structure, which is the subepicardial late gadolinium enhancement. So after this finding, we take a look at the ECG again, and then we notice that there's this epsilon wave in right precordial leads, and also that there are inverted T waves in left precordial leads. So our first conclusion was that this is fulminant phase of myocarditis. So according to guidelines, we did endomyocardial biopsy, where we could see these white regions of fatty tissue, also this fibrous tissue replacement, and also there was a presence of significant inflammatory infiltration. On a side note, I would like to note that PCR from myocardium was negative for all cardiotropic viruses and borreliosis. So this is just the summary of our findings. And then we did also the genetic testing. So there was found a presence of two mutations for genes encoding desmosome proteins. And the first one he inherited from his father, and the second one, the likely pathogenic desmoplakin, he inherited from his mother. So our final conclusion, based on those findings and based on PEDUA criteria and the presence of significant inflammatory infiltration, is that this is a hot phase of biventricular arrhythmogenic cardiomyopathy, which basically means that there is a myocarditis-like episodes in patients with ACM. And for the treatment, we continued with the guideline-directed medical therapy for heart failure. We did the ICD implantation, and because it was virus-negative lymphocytic myocarditis, we started with immunosuppressive therapy. Then there is a follow-up from March 2023, where the patient is clinically stable. There are no crackles, no peripheral edema. The NT-proBNP is lower. Then on ICD checkup there were 0 shocks, and what's important that the left ventricle ejection fraction improved to 40%. Also, in case of worsening condition, there was examination for heart transplantation performed, and patient was put on a waiting list for heart transplantation. So, as a conclusion, I would like to say that this is a clinic case that shows 15-year-old patient carrying DSP mutation, which led to biventricular type of ACM. Also, it documents myocarditis-like episodes, which are called hot phases, and it's myocardial injury accompanied by ECG changes and cardiac biomarkers. So these hot phases can be also the initial presentation of ACM, and what's most important, that the combination of heart failure therapy and immunosuppressive therapy led to improved heart function in our patient. But evidence supporting tailored risk factors, clinical decision-making and target therapy in patients with hot phase episodes in ACM is currently lacking. Thank you for your attention.
Thank you, Karolína. So the floor is open for discussion. There are any questions from the audience? Yeah, thank you.
You have had, thank you for a great presentation, Karolína. You had in bracelets the VOS after plakophilin. What does it really mean?
That means that it's a variant of unknown significance. There is a mutation, but we don't know its significance to the organism.
Thank you.
Thank you. If there are no any urgent question, I would move on with the next speaker. Thank you.
Thank you so much.
Thank you.